Hello, I'm Al George. I'm the professor and chairman of the Department of Pharmacology at Northwestern University's Feinberg School of Medicine, and I'm pleased to share with you some of our work on SCN2A, in particular how we've approached the characterization of the function and pharmacology of a variety of SCN2A variants. As probably many of you have learned, there is this current dogma that SCN variants can either be associated with a gain of function or a loss of function, and that creates the backdrop for a clinical spectrum from severe epileptic encephalopathy, where we expect to see the most significant gain of function variants, all the way to the loss of function variants, which are more likely associated with autism spectrum disorder and intellectual disability. And in the middle, there is some defined normal level of function. And so this brings up a couple of important questions, which is, how do we determine the function of an SCN2A variant? And once we do that, do we really learn that there are only two possible functional outcomes? And then lastly, once we know something about the function of a variant, does that help us select an anti-epilepsy drug when that's relevant? So those are some questions I'm going to try to address in my short talk today. First question is, how do we determine the function of a genetic variant in SCN2A? The classic way of doing this is referred to as the area of electrophysiology, and in particular, a specific technique called patch clamp recording. This is a well-established methodology that's been used for decades to understand the biology and physiology of ion channels in different systems. And the way we and many other laboratories use this method to study genetic variants is we introduce a recombinant or cloned human version of SCN2A into a cell that normally doesn't have sodium channels, in particular doesn't have SCN2A there, and then we can record from that individual cell using this method called patch clamp recording. This is a technique that requires an expert who's skilled in the art of recording, and they have to use some pretty sophisticated equipment to make that recording. But the bottom line, it's a very robust and very reliable technique. However, it's slow and tedious. And so it may take a skilled operator several days or a couple of weeks to study one mutation. But as many of you know, there are hundreds of mutations in SCN2A. And so to get through those, we've adopted a different strategy. In my lab, starting about 6 years ago, we acquired an instrument that was developed for drug development and drug discovery for the pharmaceutical industry. And this instrument we've now repurposed to be able to use for performing higher throughput studies of SCN2A and other ion channel variants, in fact. This is a patch clamp machine that automates the process and then performs the process in 384 well format. So we can, instead of doing one cell at a time, we can measure hundreds of cells at a time. And that has greatly increased the possibility of studying multiple variants per day, or at least accelerating the process of looking at hundreds of variants. The nickname for our machine is shown here, Das Machine. It simply reflects the fact that we got the machine from a German vendor, and then we butchered the German language to come up with this nice nickname. Just to show you a little bit about the raw data, this is a schematic of what is the traditional form of patch clamp recording, which is one cell at a time. You place a glass microelectrode on the surface of the cell, and you can capture the electrical activity very simply by using the right electronics. So this is a raw recording of some sodium current from a cell that expresses a sodium channel, probably SCN2A in this case. The automated patch clamp uses a completely different strategy, and that's why it can be done in a parallel fashion. And these are the raw data from that instrument, which is a 380 well format showing you rows and columns of individual recordings all lined up with one another. So this can really give us a lot more data in a shorter period of time. You can think of this as manual patch clamp being your classic locomotive, and automated patch clamp being something slick like a magnetic levitation train. So just to get into some of the weeds, we use a recombinant human SCN2A plasmid DNA. That's a way of carrying the parts of the gene that we want to study into some kind of laboratory-grown cells. In this case, we use a cell line called HEK293, and we've modified those cells so they contain the two important accessory subunits of SCN2A called the beta-1 and beta-2 subunits. We introduce the DNA into the cells using a quick pulse of electricity, a process called electroporation, and we've optimized this process so that we can get very uniform distribution of SCN2A channels into the cells at a high enough efficiency to use the automated patch clamp instrument I showed before. So what I'm going to show you today is just a snippet of some of the work we're doing. And the first batch of SCN2A variants that I'm going to show you came from a genotype-phenotype study that was conducted by John Millichap in partnership with your foundation. And here is a list of the variants that he has collected extensive clinical information on, including their general neurological features. Did they have seizures or not? Did they develop normally or not? And also importantly, the age of onset of those symptoms. And so you can see here that many of these mutations were associated with very early onset, in this case mostly epilepsy, with the age of onset in months is listed here as 0. In performing these studies, we thought it was important to study SCN2A in its two forms. And what I mean by that is SCN2A undergoes what's called alternative splicing, in which means it exists as two different forms during different phases of development. What we use and this arises because of the fact that SCN2A, the gene, has two mutually exclusive components that we call exons that are alternatively used. In early development, through probably sometime in very late infancy, there is a preferential use of what we call the neonatal exon, and later on in later childhood and adult, we have the adult exon enumerated here as exon 6. These generate two different forms of SCN2A that can give rise to subtly different functional properties. And in a prior study that we did, we demonstrated that there are some mutations that are associated with early onset epilepsy that tend to show worse functional effects when they're present in the neonatal form. And so for most of the variants that we studied, 21 of the variants were associated with early onset disease, and we studied them in both the neonatal and adult forms of SCN2A. 6 variants which were later onset in symptomatology, we only studied in the adult form. And then there was one curious variant that was, the variant itself arises in the neonatal exon. So therefore, we only studied it in that version because it wasn't found in the adult form. Another thing from John Millichap's study that we also wanted to follow up on was the fact that he had collated information about the response to anti-epileptic drugs. And in particular, we looked at the response to those drugs that were known to block sodium channels, including SCN2A. And so on the chart here, you can see colored in green are those individuals and their variants for which there was a positive response to sodium channel blockers. And those in red were those that didn't respond. And then many of the others were either mixed effects or the drugs were not tried or we just didn't know if they were tried. So in the next few screens, I'm going to show you some representative recordings from cells that had these different genetic variants in SCN2A. If there was no sodium channel in the cell or the sodium channel was completely non-functional, we would see something as illustrated in the upper left of this slide labeled as empty cells, where there's just very little inward current. And this is the downward deflection of these traces. There is a little bit of endogenous or native sodium current in the cells we used, but it's not significant. And in the blue box here is what the normal or wild type WT SCN2A channel would look like. And there we get a much larger downward deflection of these recordings. These are the actual current recordings in individual cells, and we can easily distinguish normal function from no function. What becomes more challenging is to describe the more subtle features of the sodium current, and for that we actually quantify up to 10 different parameters from each individual cell. And so I can't show you all the data, but I will summarize it at the end. But I just wanted to go through and show you sort of some examples of the functional qualities of some of the variants. And I've broken them into 4 different slides showing you variants that are present in different structural domains of the SCN2A sodium channel, and also have coupled that with some coding to show you with these colored diamond symbols which variants were associated with responsiveness to sodium channel blockers, which were not responsive, and which might have had a mixed response. And so, for example, in this view, 2 of the variants were associated with a positive response to sodium channel blockers, and one had did not have a good response. In the next domain over, we see, again, a large number of variants here. Many of them have pretty robust function, but just to note a few, for example, in the upper right corner, there is one that has much diminished sodium current, although there is a flare of the current that is not coming back to zero. This is what we call persistent sodium current. This is a good example of that. Down in the lower left corner is a mutation that has very low function as well. And then in the middle here are many others that have different varieties of their functional properties. And then I'll also point out that some of these variants were associated with the later onset neurological symptoms, and those are boxed here. R853Q is a recurrent variant, and there are a number of reports with individuals who are unrelated to each other that have this variant. This tends to be associated with later onset neurological disease, as is this one here, this D1050V. And then again, using the same diamond-colored symbols before, green indicates those variants for which there was a documented good response to sodium channel blocking drugs, and the red diamonds represent those that did not respond. Importantly, the 2 late onset variants in this slide did not respond well, and that's something that people have known about. But importantly, many of the other variants had sort of either no response despite the fact that they had early onset seizures, or had a mixed response despite the fact that they had very low current. Finally, here's 2 more slides. Here's domain 3. There were 2 late onset variants, and then many of these had a positive response to sodium channel blockers. Note that here is a late onset case with with a mutation called E1211K that was associated with a good response to sodium channel blockers. And then the last domain of the channel, where we have many, many more variants, only one was a late onset, and it's the one with the least current, so a loss of function. And then a few variants here were associated with good response to sodium channel blockers. Both of these variants we know are classically considered as gain of function, and another gain of function variant at the top, and then one loss of function, one non-responsive variant. So I know that's a lot to go through, but here, that's just a sampling of the kind of data that we collect, and that would be what we call the current density of the sodium channel. But in addition to that, we collect data on many more parameters, and some of these measurements actually have multiple parameters inside the measurement. And so we gather probably around 14 to 15 different quantitative measures of the variant function. And for each individual variant, we can assess whether the difference that we observe between the normal SCN2A channel and the variant could be characterized as a loss of function or a gain of function. That's for each individual parameter that we study. And to make that kind of come to life, we've decided to actually use this color coding scheme against all of these functional parameters for all of the variants that I just showed you. And that creates what we call a heat map, where for each variant shown here on a row, and some of these variants were expressed in both the neonatal and the adult isoforms, some were only in the neonatal, some are only in the adult. But for each of these variants, as you look across the rows, there is a number of columns here which reflect the different functional parameters that we measured. Current density is just the first column, but there are many others here. There's persistent current, and the rate of inactivation, the voltage dependence of inactivation and activation. And so what you can see by this color coding, and this is just the other half of the variance, if you see red, this is reflective of a loss of function of that property for that variant, whereas green and darker green means gain of function for that property for that variant. And so I think it should be obvious that it's not a simple matter of variants having just gain of function or just loss of function. Most of the variants we've studied in this group have very mixed effects. Now, there may be predominance of one effect or another. For example, R1626Q we regard as a gain of function variant because the rate of inactivation, the presence of persistent current are probably the dominant drivers of the activity in that case. Although there are some other properties that would tend to offset it, we think these are probably the more dominant forms. But that's a difficult assessment to make. For other variants, for example, maybe we just go back to some of these others, G882E, this had very low current density. It had changes in recovery from inactivation that were all very consistent with a very strong loss of function property. But there were other properties that suggested maybe a gain of function or normal function. But again, we think that predominantly this one would be a loss of function. But this is a difficult thing to assess, and so I just want to emphasize this point that there is some challenges to use this simple binary classifier of SCN2A variants. Loss of function, simple loss of function sometimes is pretty obvious. Simple gain of function sometimes is pretty obvious. But I think the majority of the variants that we've studied to date are not that simple. We can't easily categorize them one way or the other. That said, when we can characterize them, there may be some clues as to what is the best pharmacological approach to correct the problem. So as I emphasized before, we had variants that we knew the patients were exposed to sodium channel blocking drugs but were not responsive, whereas others were responsive. And so we looked at the heat map of those two groups of variants. And again, what we see is somewhat of a mixed picture. For the non-responsive variants, we would expect that for those variants that had loss of function, there's no benefit to further blocking sodium channels. And so those might be the individuals who are less likely to show a positive response to sodium channel blocking drugs. By contrast, those individuals that have predominant gain of function properties associated with their SCN2A variant might be those individuals who would respond best to sodium channel blocking drugs. But again, we see sort of a mixed picture here, and it's going to take more time to sort out how these all sort out. Another way to approach this is to actually test pharmacology on individual variants, and that's something we've begun to do in select cases. So I'm going to leave you with one final set of a few slides where we have done the pharmacological assessment on a genetic variant associated with early onset epilepsy. So this is a case that was communicated to us by Linda Laux at Lurie Children's Hospital in Chicago. This was a child that had the onset of multifocal clonic seizures at day 3 of life. And then at 1 month of age, they had already identified a genetic variant, an SCN2A, that was classified as a variant of unknown significance. And we went to work. And we performed both the electrophysiological study as well as a pharmacological evaluation. And the data I'll show you just summarizes briefly the properties of the variant channel. So the particular variant was called F1574L, and that is shown here as a blue line next to black lines, which represent the wild-type channel or the normal channel, and then a different variant with a red line that we just happened to study at the same time, and I won't say any more about that. The blue line represents the current carried by this channel over the course of several tens of milliseconds. And in comparison to the wild-type channel, the F1574L variant has much slower inactivation, and that's the falling phase of this current back to near the baseline. And that causes there to be the opportunity for more sodium current to pass into the cell over this short time window compared to the wild-type channel. And so this would be considered a gain of function. These channels open and stay open longer than normal, and therefore the amount of sodium flowing into the cell is going to be greater over time. So that gain of function was one of 2 properties that this channel exhibited that were both consistent with a gain of activity. And therefore, this might be a channel variant that would be responsive to sodium channel blocking drugs. So the question is, which one? So we did some pharmacological profiling that is summarized here, where we examined the properties, many properties, but one particular property that we show here is referred to as use-dependent block of the channel by different drugs. And the drugs are listed here and also below. DMSO is not a drug. This is a chemical that we use to dissolve the drugs, and therefore we need to check to make sure that itself isn't affecting the channel. And then this list of 8 or so drugs, including lamotrigine, topiramate, BIA 2093 is the active form of the drug oxcarbazepine, carbamazepine, lacosamide, and some other blockers, drugs that can also block sodium channels are included. And each of these bars represent the degree of inhibition of this gain-of-function mutation by each drug with the listed concentration. And in this particular experiment, lacosamide, to our surprise, showed the greatest degree of inhibition. Now, it was followed closely by at least 3 other drugs, but we communicated this information to the physician in charge, and they chose to try lacosamide. And a preliminary report back to us a few months later suggested that there was a good response to that drug. So this is a paradigm that some have referred to as precision medicine. Can we use this kind of technology to zero in on what is the best drug for this individual patient? I think the default would have been probably to try carbamazepine. But in our hands, in this particular experiment, carbamazepine was really not very effective at suppressing the activity of this particular variant. Lacosamide, which would not have probably been considered a first-line drug, was the one that emerged as the one to try, and it seems clinically to have been successful. So I will leave you just with a picture of what has become an old picture of my lab, but some of the members of the team are still there in the picture. But the people who are responsible for this work include Franck Poteet, Chris Thompson, Carlos Vanoy, who are the major electrophysiologists in the group. Scott Adney did some of the study on one of the mutations as well before he went off to do a neurology or epilepsy fellowship. And then some technical people in my lab, John Mark de Kaiser, Tatiana, and Nora, all important for getting these mutations generated and put into cells. And I, of course, mentioned John Millichap, whose work many of the data I showed was based on, and Linda, who contributed the report of the last case. And much of this work is supported by our Center Without Walls grant from the National Institutes of Neurological Disorders and Stroke. And we're also happy to say that we've been funded recently by the Simons Foundation for work that will be ongoing over the next couple of years to study some additional SCN2A variants associated with autism spectrum. Thanks.
Hi there, this is Mery Oman and Matt Oman. I'm actually a member of the board, and we have our son Ethan who has SCN2A and started with seizures since birth. So he's what we assume is a gain of function because he's responded very well to sodium channel blockers. But from our understanding, his variant has not been studied yet, is what Al and his lab are doing. So our question is, how do you choose your variants that you study, and do you plan to study all the variants that are out there that are known?
Yeah, so right now we have multiple strategies to select variants. What I illustrated in my talk was a defined set of variants for which there was good clinical information and pharmacological response data, and that became kind of our initial foray into this area. But as part of our Center Without Walls, I have a very talented group of colleagues, including Ingo Helbig and Ed Cooper, who are important for the center's variant prioritization core facility. And I leave it up to them to tell us which variants are the most valuable to study. And there's several criteria they use. First of all and foremost, we want to have deep clinical information about the individual who has the variant so that we can extract good genotype-phenotype correlations. As part of that, I've requested that they try to find variants for which we know of the drug responsiveness of the patient. And then third, they look for the most recurrent variants, those that show up in more than one person. And then lastly, we are looking at some variants that have been studied by other groups to calibrate our functional assay, but to also begin to look at many more. So I've shown you a list of a group of close to 30 variants that we've completed, and we'll be writing a manuscript about those. We're actually planning to discuss these data at the AES meeting virtually this year. And then to follow up on that, we have another list of 54 variants that we have begun to make and will be studied here in the next several months, or a few months hopefully. And those were all selected for us using the criteria I mentioned before. In a separate study, which is being funded now by the Simons Foundation, we're looking predominantly at for the Simons Foundation, we're going to be looking at as many, if not all, of the variants associated with autism spectrum disorder, whereas our Center Without Walls, funded by the National Institutes of Health, is really devoted to studying epilepsy-associated variants. So hopefully by the combination of those two funding mechanisms, we'll have the opportunity to study at least a couple of hundred, if not more, variants. Can we study all the variants that are out there? Well, if people would stop finding them, maybe we could catch up. But there are a lot, and we'll do our best to study as many as we can.
True. Now, is this something that you could obtain? Could providers obtain the results of this as in a report form? Or like parents can obtain this in the future?
Yeah, so we have thought that the best way to disseminate the information that we're collecting is once we've decided that we are at a final result stage where we've done all the quality control and we have finalized the results, the best thing we can do is to place the result in a publicly accessible database. And what we are working on actively with my colleagues, predominantly Ingo Helbig and his team at Children's Hospital of Philadelphia, is to get the data into ClinVar, which is a publicly accessible database of genetic variants. You don't need a password, you don't need a membership, you don't have to pay anything. Anybody can log in and look it up on the internet. And we've started a pilot project where we have developed with the collaboration of the ClinVar team a way of putting the data in. And so it's still a work in progress, but I think as soon as we work out a few more kinks, we're going to be starting to dump in the data into ClinVar so that if you look up a variant, and we have done functional studies, that functional result will be there and described in a way that could be understood. And in addition, we'll have links to the more hardcore data if someone wants to look at more information. Ultimately, we'll put this information out there in peer-reviewed publications, but we don't want the world to wait that long for it, so we're trying to use ClinVar as our immediate vehicle for that. So hopefully starting soon, we'll be able to start to use that. In the interim, people can contact me and ask if we've studied their variant, and we're very happy to let them know if we have, and to have a chat with them or their providers as to what we found. But an important element here is we're a research laboratory, and we can't send out a formal report like the genetic testing companies do. I mean, that's not something we're technically allowed to do, but we can discuss the results with families and with caregivers where necessary.
I mean, you talked a lot about the variability of your findings with all the mixed results. So in terms of treatment, it's very obvious that the gain of function patients respond very well to the sodium channel blockers, but the loss of function, what do they respond to? The very severe, obvious loss of function. It's kind of a hard...
Yeah, that's much more difficult, and I don't think there's an easy answer to that. What I would say is that someone with severe loss of function of SCN2A probably is not a great candidate for the type of anticonvulsant drugs that block sodium channels. And so alternatives should be probably preferentially tried. That said, there's still a lot we don't know about the brain, and how individuals respond to different drugs sometimes has to just be determined empirically with trial and error. What we hope to do is maybe identify those variants that have the highest likelihood of responding well to sodium channel blockers so that those drugs can be preferentially or prioritized versus other mutations where you wouldn't expect a sodium channel blocker to help, and in those cases maybe clinicians can prioritize drugs with other mechanisms of action to try first.
Makes sense. What I thought was interesting when you showed the slides of the pharma evaluations and you listed all the sodium channel blockers that were there, what was interesting was that phenytoin wasn't there. And phenytoin is one of the drugs that are most, studied with SCN2A in the prior papers.
Yeah. So that was in that experiment. I think phenytoin's a tricky drug to use in the laboratory. It has some problems dissolving in solutions, and we can't use the high enough concentrations to get effects that we want. So we do intend to include phenytoin in our studies. In that particular one, we just weren't happy with the conditions, and so we dropped it. Phenytoin and carbamazepine are very similar in their effects, and will often individuals who respond to one will likely respond to the other. But I do agree phenytoin should be always on the list, and we will try to include it. But it is a tough drug to work with just from a chemical point of view.
And we would agree that it's a tough drug to work with in real life, because it's very hard to get those levels steady, like you said. And if we had gone through this experience, it'd be so interesting to just see, because actually our son responds very well to Vimpat right now, and that wasn't really trialed initially, so it's very relevant, I think, to many of us. So
another question?
I think one question that would come up for people is such as the case study that you had where the other physicians consulted you and you ran the testing and showed which medications work best for that patient who had early onset seizures, is there an opportunity for other families or physicians to have their patients be tested by your lab to determine, what would work best for their child or patient?
Yeah.
That acute setting.
In the acute setting.
Yeah, so a couple of things. We would like to be doing more of that work. The tricky part is that it has to be done early on in the life of the child, because after months or years of having a seizure disorder, brains change, and they probably undergo changes that may reflect things that are not part of the original genetic etiology of the epilepsy. So what we think is best is to try to identify children under the age of 3 months who've had early onset seizures for whom a genetic test result has come back with a sodium channel mutation. And so we are eager to study those early diagnosed cases as soon as we can. We've had a good relationship with our colleagues at Lurie Children's Hospital here in Chicago, where they know when to alert us for such cases, and I illustrated one in my talk. But we are actively open to doing that. It takes about a month to 6 weeks to complete the functional and pharmacological study, and that's kind of an average time. But there are a lot of factors that fall into that. But if we do have a compelling case where it would be valuable to know the functional effect and the pharmacological effect, we tend to drop what we're doing and try to study those. But
I guess we wanted to ask you what else do you guys study at the Centers Without Walls? Do you focus mostly on sodium channels, or do you focus equally on other channels as well?
Right now, we are about equally split between sodium channels and some potassium channels. We've done a tremendous amount of work on KCNQ2 variants and are currently writing up a paper in which we studied about 80 variants in that gene, and we have another 50 or so in the pipeline getting ready to go. With the sodium channels, we've studied mostly SCN2A. I think we have finally optimized the assay conditions to allow us to study SCN8A variants, and we do also SCN1A, but we're not putting we don't put a lot of effort behind SCN1A. We're trying a different strategy to try to look at variants in SCN1A at the moment. But potassium channels and sodium channels have been sort of our major bread and butter for the center.
Awesome. What have you learned about SCN2A through your work all these years so far as you continue to research and learn?
I think that we've learned quite a few things, some of which I touched on in my talk. I think the most important thing that we're realizing of late is this notion that we can't really easily and simply characterize variance as gain or loss. Those are helpful terms, and I think there will still be value in labeling variance when we're confident that that is a good descriptor. But many of the variants that we're seeing, as illustrated by the study I presented, are mixed, and they have mixed functionality. And so there's going to be a need to do something more than the assays that I described. Probably something along the lines of looking at the function of these sodium channel variants in a neuron at some level. That could be an actual neuron, it could be a computationally created neuron, and there are people that are actively working on approaches to doing that. And I think that's going to be the next major challenge, is to try to determine which functional properties that we measure are most physiologically relevant, and to what extent does a change in current density or voltage dependence of activation, or many of the other things we measure, how much of a change matters physiologically and is relevant to the disease. So those are important things that I think we've learned, and there's a lot more to do, of course.
It's great. I mean, to think of where we've come along so far, like all these years since, especially with our foundation just starting just a couple years ago, on just the science that has evolved and everything that we've learned so much. It's pretty amazing, the progress that has been made. And that's thanks to you and all the researchers who've devoted their time to this disease.
Well, we're also, we appreciate greatly that we have the opportunity to interact with the foundation for a couple of reasons. First of all, this isn't about what we do in our lab, and it's not about our resumes and our papers. This is about helping somebody. And what we learn needs to be applied to that end. Second is, as many of my colleagues who attend these foundation-sponsored meetings, attending those meetings gives us a lot of inspiration and a lot of motivation. And so I'm glad that you hold these events, and I will always show up for them.
Thank you. The feelings are reciprocal, as we felt the same way attending the events, and it just gives us so much hope. So thank you.